right? All right, so today we'll be talking about nephrotoxins. It is a very, very wide topic. So what we will do is we will talk about some select ones and then go over some of the vignettes actually that will be interesting from a board perspective as well. So the objectives are we will understand the pathophysiologic basis for some hand-selected examples of nephrotoxins, and then we'll go over some vignettes for the board. So what is nephrotoxicity? So nephrotoxicity refers to functional or structural damage to the kidneys that develop after exposure to certain substances. They could be various drugs, they could be diagnostic technique, medications, and certain toxins. Now, when we say functional renal disorder, we are talking about damage to the glomerulus, tubules, or the kidney mechanisms that control other things like blood pressure, and the disruption of the kidney endocrine function, so like the DSA. The structural lesion, on the other hand, may not cause a functional impairment, but cause something that you can see under the microscope, so like microscopic glomerular injury, tubular pathology, or just scarring over a period of time, including cortical necrosis or cortical atrophy. So why is the kidney so vulnerable? Because the kidneys, for the most part, tend to be the final path for excretion of exogenous materials, especially if they are hydrophobic substances. And then of course, there are several medications that can alter the renal hemodynamics. So thinking about the kidneys, the glomerulus, which is the basic unit of the kidneys, very much depends on the renal perfusion pressure for its filtering mechanism. So anything that alters the renal hemodynamics will make the kidneys at risk for ischemic damage. In addition to that, the kidneys is one of the organs that uses a very large amount of energy and oxygen per gram of tissue, even higher than the heart. And this large amount of energy consumption and oxygen requirement makes it more susceptible to damage if that energy or oxygen supply was to be affected. In this picture here, I'm showing the proximal tubule, and the proximal convoluted tubule, you can see how rich in mitochondria these tubules are. And that is parallel to how much energy requirement and oxygen requirement the proximal tubule has. In addition, I wanted to show you, so the lower part is the basal membrane, and the top part is the apical membrane that goes towards the lumen. And you can see that the mitochondria are actually parallel to the direction from the basolator to the apical membrane. And that is exactly because when materials are transported from the basolator membrane to the lumen, the energy provided for those transports is of course through the mitochondria. But this much mitochondria makes them very susceptible to any disruption in energy supply or oxygen supply. Now, the proximal tubular cells, in addition, have certain specific secretory pathways, and the job of those pathways is to transport material from the blood vessel to the cellular tissue and from the cell to the lumen. So you can see that if some material is transported from the blood, now initially through the transporters, it will actually go to the cytoplasm of the cell. And then eventually from the cytoplasm, they will secreted into the tubular lumen. But during that process, the cell itself can have a very high intracellular concentration of some of these drugs. And understandably, if there was something that was to disrupt the secretory mechanism at the apical level, the cell will be very high risk for getting damaged because of those intracellular concentration of the drugs, as we will see in an example subsequently. So what is the natural history of most nephrotoxic AKI? So usually nephrotoxic AKI will be non-oliguric AKI as compared to ischemic AKI that tend to be oliguric. Typically nephrotoxic exposures will be dose dependent. I'm saying typically because that's not always true, but typically dose dependent. So more the higher concentration exposure, higher the chances of AKI. Except AIN, because AIN is a type 4 hypersensitivity. So it's an idiosyncratic reaction and is not necessarily dose dependent, just exposure dependent. The urinalysis in nephrotoxic AKI is often bland. You might see some WBCs in the urine if the drug also causes inflammation, but otherwise typically a bland urine. And then along the time, more often than not, once the nephrotoxins are removed, you see some recovery in the kidney function. Although, if the damage is severe, it can lead to overlasting damage and chronic kidney disease and fibrosis.
Can you go back one slide? This one here, mine not always is that the arrows go the other way. And I'm sure there's probably both ways of doing it, but I always thought drugs are so small, they're freely filtered. And
well, that's the glomerular after the filtering, what happens in the proximal tubules is a lot of secretion happens.
Okay.
So the drugs, for example, we will look into one of them. I don't want to give it out. You will see that after filtration, some of them are actually secretion dependent.
Okay.
Now, if they're secretion dependent, how the drug moves is actually from the cells. They actually go intracellular through some of these transport mechanisms. And then from the intracellular, there are another transport mechanisms that will drive them into the lumen. Now, if anything interrupts these transport mechanisms on the luminous side, then the cell will basically just keep having more and more concentration of the drug and making it likely to sustain damage. So what are the signs of nephrotoxic injury? So, of course, at the glomerulus level, the afferent arteriole, constriction of the afferent arteriole can affect the GFR, like calcineurin inhibitors, NSAIDs, COX-2 inhibitors, and aminoglycosides, and of course, albumin contrast. Anything that affects the efferent arteriole vasoconstriction, like ACE inhibitors and ARBs, can affect the GFR. I want to be careful to say what can affect GFR and what is nephrotoxic. ACE inhibitors and ARBs are not nephrotoxic; they're actually kidney protective. Just the hemodynamics in the wrong circumstances can cause GFR reduction. But there are, of course, different materials that can affect the glomerulus, like NSAIDs, colsaws, penicillamine, they can directly affect glomerular injury and cause AKI. There are medications that will affect proximal tubule and distal tubule and can cause ATM, like aminoglycosides, amphotericin, ifosfamide, cisplatin, and identity contrast. A lot of materials will cause crystalline nephropathy. For example, acyclovir, ampicillin, sulfonamides, and methotrexate are known for crystal nephropathy if the urine is very concentrated with these drugs. And then very separately, interstitial nephritis, because this is not a directly nephrotoxic injury, this is a type 4 hypersensitivity, can happen because of a lot of antibiotic and also because of some other medications like carmazepine and calcineurin inhibitors. So just trying to show you the sites of nephrotoxic injuries, that not all nephrotoxins cause the same kind of kidney damage. What kind of kidney damage we see, what repercussions they have in the long term, depends on where they are affected. And why this is also important is because of this. So more and more biomarkers of nephrotoxic injuries are being determined, and this is definitely a work in urinary proteomics right now. But this is just an example that we know some materials are, some of these biomarkers are affected in certain particular parts of the kidney. For example, the plasma NGAL is increased in ischemic tubular injury. On the other hand, urinary interleukin 18 is increased whenever there is inflammation in the tubular institution. So this is very much a work in progress, and we are realizing that there are some biomarkers that will be particular, going back to the site of the kidney injury. And maybe at some point we will have particular testing panels where we can do the panels and actually determine the site of the injury and differentiate these nephrotoxins. So for example, we know at this point in time, and this can be a board question, increasing urinary CXCL9, interleukin 9, and telomerase process factor alpha. When you see these three together, that is a very high probability for interstitial nephritis. So over a period of time, with all of these different biomarkers, hopefully we will have separate panels for proximal tubular injury, for glomerular injury, and injuries that we can determine even before the GFR or the creatinine is affected.
But there is a scenario because in acute interstitial nephritis, we have a gold standard test like white blood cells cast.
Well, white blood cell cast is not gold standard because not all AIN will give you white blood cell cast, for one. And then two, white blood cell cast can actually happen in pyelonephritis as well. So having white blood cell cast gives you an idea about the AIN in the right scenario, but it is not diagnostic. The idea about these urinary biomarkers is to catch the kidney disease or AKI even before you see creatinine or BUN elevation, right? So think about patients who get oncology medications. If we can catch kidney damage before it actually manifests in blood work, then we can impact the treatment sooner, right? That's the idea of biomarkers.
Dr. Rathi,
yes.
Just to answer Dr. Yunus' question, gold standard for AIN is kidney biopsy in board question. The answer is.
Yeah, there's no diagnosis. Because in a lot of AIN, you will actually not get any urinary changes.
Yeah, the ultimate answer is kidney biopsy.
Yeah. So that's why knowing the site of these nephrotoxins will help us in future, because at some point we'll be able to use biomarkers. Okay, so we're going to dive into some vignettes. So it's going to be a little bit of vignette-based teaching. So question one, a 21-year-old male presents with back pain and malaise. Patient is an avid marathon runner. doctor, and after a strenuous training last week, he had been taking a few doses of ibuprofen and naproxen. He does not have any fever, and the urine output is reported to be normal. His blood pressure is normal, 120/76. Examination does not reveal any edema. His creatinine, on the other hand, is 3.6 milligram per deciliter. The most likely finding on urinalysis would be: 1. Is it 1 plus mean, 1 plus decasterase, more than 100 WBCs per high bar meal? Is it going to be bland urine with trace protein? Is it going to be dysmorphic RBCs, RBC casts, and heavy proteinuria? Or is it going to be muddy brown casts and debris? We will come back to the question. So talking about NSAIDs, so number one problem that nephrologists will be linked with. So how do NSAIDs affect kidney hemodynamics? So trying to show the glomerulus, this is the afferent tubule arteriole, and this is the efferent arteriole. The afferent arteriole is, of course, the feeding pipe to the glomerulus, and the glomerulus depends on the blood flow and the pressure coming from the afferent arteriole. The afferent arteriole vasodilatation here is mediated by prostaglandins, prostacyclin, PGI2, and prostaglandin P2. And COX inhibitors, so cyclooxygenase 1 and cyclooxygenase 2, is responsible for this vasodilatation. Any COX inhibitor will actually cause prostaglandin levels to go down, and that will cause the afferent arterioles to go down, to collapse. If the afferent arteriole pressure is reduced, understandably the pressure in the glomerulus is reduced. If the filtering pressure in the glomerulus is reduced, the glomerular filtration, which is completely pressure and hemodynamics and osmolarity dependent, will be reduced as well. So you can see how NSAIDs cause vasoconstriction, and that will cause the GFR to reduce. Now, thinking about this is purely hemodynamic, right? If you gave somebody NSAIDs, okay, their GFR reduced, so what? Where's the rest of the damage? Because we see a lot more problems from NSAIDs rather than just a hemodynamic change that sounds reversible. So NSAIDs can actually cause acute kidney injury in multiple ways. They can cause acute kidney injury because of the hemodynamic mediated damage that we just saw. It can actually cause acute tubular necrosis. They can cause acute interstitial nephritis. They can cause nephrotic syndrome by directly affecting the glomerulus and presents in the way of minimal change or membranous nephropathy. If concomitant administration is done with Tylenol, it can cause acute papillary necrosis. And then over a period of long term, NSAID can cause chronic interstitial nephritis. So how is it? Because what we just talked about on the previous slide does not explain any of the other things, right? How does it cause nephrotic syndrome? How does it cause acute interstitial nephritis? So it turns out that in the nephron, there are two types of cyclooxygenases, cyclooxygenase 1 and cyclooxygenase 2. And the function of a lot of the nephron depends on the ratios of cyclooxygenase 1 and cyclooxygenase 2. So for example, I'm trying to show that the cyclooxygenase 2 lives in the glomerulus, in the loop of Henle, in the macula densa, and in the medullary interstitial cells, right? On the other hand, cyclooxygenase 1 is predominant in the other areas that are marked. So NSAIDs, what they do is because they affect cyclooxygenase 1 and cyclooxygenase 2 ratio, they can affect these two different sections of the nephron. So for example, if you were to give an NSAID and it affected the cyclooxygenase 1 into the glomerulus, that's how the podocytes can be affected. The podocytes are actually rich in COX-1 and 2 as well. And that can cause minimal change disease and membranous nephropathy. If it affects the loop of Henle, that's how you actually get tubular necrosis and you get an ATN. If it affects the macula densa, it affects the renal hemodynamics. Remember how NSAIDs can actually cause hypertension and resistant hypertension? It's because of the macula densa effect. And then over a period of time, when NSAIDs are given over a long time to people, the medullary interstitial cells can be affected, they turn into fibroblasts, and that causes chronic interstitial nephritis and fibrosis. So NSAIDs have multiple mechanisms of affecting the kidneys, depending on the NSAID and depending on how long these happen. And this is why when selective COX inhibitors came out, like celecoxib, everybody thought that they're going to be less nephrotoxic. Turns out they are as nephrotoxic as non-selective COX inhibitors, because at the end of the day, they are also changing the ratios of the COX-1 and COX-2 in the kidney.
I never seen this. This is really interesting. Right?
Yeah.
Where did you find that? Did you make this graph or you found it?
This?
Yeah.
No, I got it from one of the articles
That's great.
on COX. Yeah.
Meaning it is not like GI, because GI position like COX-2 than COX-1.
Exactly.
As a nephrologist, both. We have both.
Because it depends on the ratios.
As an
So going back to our question.
I thought That was my big thing with the hemodynamic. Was
But then you think it would be reversible, right? How does it cause chronic interstitial nephritis? How does it cause APN then? Because we are just talking about hemodialysis. So what do you think is the answer to this question? So in a patient who's taking NSAIDs, creatinine is 3.6, is making good urine, blood pressure is normal. The most likely findings in analysis will be what? So let's go about one by one. So what is A? 1 plus heme, 1 plus decastrase, more than 100 WBCs for hypertrophy. What is
that?
UTI, infection.
UTI? Yes, why heme? Okay, because of the UTI. Right, so UTI can do that, and what else can show? Well, 100 WBCs.
Well, this is the one heme positive, right?
1 plus heme.
And then one by one plus
from
is one
anywhere.
sorry, 1 plus is one more than 100, sorry.
Right. So interstitial nephritis can do that,
Yeah, yeah.
right? Or pyelonephritis can do that. Now, number 2, gland urine with trace protein. Well, we said at the beginning of the slide that a lot of nephrotoxic exposures can cause gland, so that's a possibility.
Yeah.
What is C? Dysmorphic RBCs, RBC casts, and heavy proteinuria. What? Rhabdo. Will rhabdo cause RBC casts? Or dysmorphic RBCs? So that's glomerular damage, that's nephrotic syndrome. And D is monogrammed cast and debris. That happens in
Tubular injury.
what?
Tubular.
Tubular injury, circulatory necrosis. Now, in this patient who is actually athletic, otherwise very well hydrated, no baseline kidney function, the more than likely that issue, if it is purely hemodynamic at this very time, because remember, he took just a few doses of NSAIDs, then maybe it is just hemodynamic, and the most likely scenario that you might get is gland urinalysis with trace protein, although any of the others can happen as well, except the dysmorphic RBCs, which happen in glomerulonephritis, and NSAIDs usually cause nephrotic syndrome, not glomerulonephritis.
But here is Dr. The blood pressure is not up, like it's acute, it's not chronic, right?
It is acute.
Okay.
Okay, so next question. Extended interval aminoglycoside dosing decreases the incidence of nephrotoxicity over conventional multiple time dosing regimen by which of the following mechanism? So do you guys know what is extended interval aminoglycoside dosing? So it used to be that aminoglycosides like gentamicin or amikacin will be given multiple times a day, like Q8 hourly dosing. And then turns out that if you give them less often, like just once a day, but higher milligram to per kilogram, so higher dose just once a day, that tends to be less nephrotoxic. So the question is, how does that happen? So is it because of the dilatation of the afferent arterioles at high doses, which decrease glomerular capillary pressure? Is it because of saturation of the proximal tubular uptake sites, allowing excretion of the remaining aminoglycosides? Is it because of aminoglycoside top concentrations will be consistently less than 2? Or is it because of shorter total length of treatment with once daily dosing compared with multi-day dosing? We will again come back to the question after we discuss. So aminoglycosides. So aminoglycosides represent a group of antibiotics that include, of course, gentamicin, streptomycin, and amikacin. Aminoglycosides are bactericidal, and the very important thing to know is they are concentrated dependent killers, which means higher concentration will be more lethal to the bacteria. They are effective against numerous aerobic gram-negative and gram-positive microorganisms. That's why they are still used so often, especially in addition to other antibiotics to increase their cycle activity. Inhibition of synthesis of the bacterial protein is how they work. Now, for aminoglycosides, around 99% of them will be excreted through the kidneys. So the kidneys are the route of their elimination. Another important point to know is aminoglycosides are positively charged molecules. And why that is important is we'll come back to the mechanism. So this is a proximal tubular cell. Now imagine there is a glomerulus up front. Aminoglycosides will be filtered at the glomerular level, right? Now once the aminoglycoside is filtered at the glomerular level, what happens in the proximal tubule is the proximal tubule on the apical lumen side has certain transporters that are called magadin tubulin receptor complex. Okay, and this can be a board question. So there are magadin tubulin receptor complex, and the job of this complex is to bind cations. So the aminoglycosides that are filtered are cations; they are positively charged molecules, right? So any excess aminoglycoside that is available here is bound to this transporter and is transmitted intracellularly. Aminoglycosides can also attach to phospholipids, and that's how they can also have higher membrane activation. Now, once they're transported intracellularly, aminoglycosides tend to concentrate into two organelles, lysosomes and mitochondria. In the mitochondria, when the aminoglycoside concentration is pretty large, it actually affects the mitochondrial function and it causes damage to the crystal and release of cytochrome C. Now, these things we will go over in cycles. So, cytochrome C leads to activation of caspases. So, let's talk about that. Cytochrome C is one of the part of the electron transport chain. And whenever cytochrome C is released from the mitochondria to the cytosol, it automatically leads to activation of caspases. Caspases are enzymes that mark a cell for autolysis. So whenever caspases are released, the cell will be basically going to autolysis mode. So that's how aminoglycosides work. Go to the cytoplasm, concentrate in the mitochondria. From the mitochondria, where there is enough concentration, cytochrome C is released, activity of caspases, and that will lead to nephrotoxicity because this tubular cell is marked for death. Same thing happens in lysosomes. When the aminoglycosides concentrate in the lysosomes, they cause lysosomal rupture, and those enzymes are released to the cytosol, again leads to lysis of the cell. Right? So aminoglycosides concentrate in the mitochondria, and that's how they cause nephrotoxicity. Again, will be a good question. Now, aminoglycosides are positively charged molecules. And that's why the nephrotoxic potential of the aminoglycosides differ. The more positively charged will be more nephrotoxic, because the more positively charged will be absorbed more at the proximity to the cell. And that's why neomycin is not given intravenously anymore, because neomycin is very positively charged and causes very bad nephrotoxicity. Amikacin is the way to go. Of course, besides positively charged, the drug doses, the more doses, more damage. The duration of administration, the more longer you give, more concentration in the mitochondria. Dosing interval, we come back to that. Pre-existing renal condition, dehydration, and the concomitant nephrotoxic exposure will of course make them more likely to get kidney damage. So there was a Cochrane review in 2019, and what that showed is once daily aminoglycoside versus 3 daily times dosing were equally effective in children with cystic fibrosis pulmonary exacerbations with regards to the improvement, but the percentage change in creatinine was significantly favored once daily treatment dosing. In children, not so much in adults, but their adult volume was actually very low. So once daily dosing compared to 3 times daily dosing, same efficacy and lower nephrotoxicity. And that's how once daily dosing came to be. And why is that? So going back to our slide, excess aminoglycoside goes and binds to magnetotubulin complex, and that's how it is taken into the cytoplasm. So if we were to give the patient a lot of aminoglycoside at one time, there are only so many magnetotubulin receptor cells in the proximal tubule, and they can be saturated. Right. Once they're saturated, that excess aminoglycoside will be excreted and would not cause any extra nephrotoxicity. But what that will do is that will allow you to have a higher concentration of aminoglycosides in the blood. And remember, aminoglycosides are concentration-dependent killers, which means you should be able to get the same efficacy with less nephrotoxicity. And that's how the concept of once daily dosing of aminoglycoside is considered to be superior to 3 daily dosing. So we don't actually do it Q8 anymore. So going back to our question, so extended interval aminoglycoside dosing increases the incidence of nephrotoxicity by which mechanism? Dilatation of the afferent arteriole, saturation of proximal tubular uptake sites, allowing excretion of the remaining molecules. Aminoglycoside trough concentration that are consistently less, but that's not true because the concentration will be more. Remember, we will be more dose. And shorter total length of treatment duration, well, not really. That is decided by the pathology. So the answer is?
Circulation.
Yep, saturation of the proximal tubular uptake site, allowing excretion of the remaining aminoglycoside. Okay, next question. 45-year-old man received kidney transplant for hepatitis C associated end-stage kidney disease. He is currently treated with sofosbuvir, tacrolimus, and ACE inhibitor. He developed renal dysfunction and his creatinine increased to 2.3 milligram per deciliter with mild proteinuria over time. Based on the renal biopsy images, which is the most likely diagnosis? So gradually this patient's creatinine is going up. And this is the biopsy report. Biopsy pattern. So what do we see? So what are these, by the way?
It's the view, right?
It's a tubule, not the glomerulus, right? We know that clearly, and this is also tubule. This is proximal convoluted tubule, this is just a convoluted tubule. What do we see in the tubules? Are these normal cells? Right. What's happening with the cells? Too many dots, right? So what's happening in these cells is actually there are a lot of vacuoles.
Right.
Right? This is microvacuolation. A lot of vacuole development in the proximal tubular cells as well as distal tubular cells. So, based on this biopsy, what is the most likely diagnosis? Is it severe acute tubular injury because of sofosbuvir, calcineurin inhibitor toxicity, polyoma virus nephropathy, kidney injury secondary to cryoglobulinemia, or diabetic nephropathy.
Tubular agent, because the main pathology in tubule, right?
So which one do you think?
I think A,
A, okay.
because
Okay, we'll come back.
now, we can go back for the question because I don't see it's already the patient already on the tacrolimus. The tacrolimus and the ACE inhibitor development function with on real biopsy imaging. What is the?
So the question is, what is the biopsy imaging?
Yeah. What is the diagnosis? Meaning of we have tubular injury. Just ask for diagnosis, right?
Right. So tubular injury because of suppository, calcineurin, polyoma, cryoglobulinemia.
No. Because here I think here we have two, A or B, but I think the HCV treatment is safer in kidney than calcineurin inhibitor.
Right. The question is A or B. Which one is it?
I know I changed my mind.
So which one is it? Let's come back to it.
Okay, cool.
So let's talk about calcineurin inhibitors,
Okay.
cyclosporin.
Okay.
So calcineurin inhibitors can cause two kinds of kidney damage. They can cause acute calcineurin toxicity and chronic calcineurin toxicity. So acute calcineurin toxicity affects arterial vasospasm. Remember the arterioles, we said calcineurin can cause vasospasm. And that's how it can cause renal perfusion and increase GFR. And acute calcineurin toxicity tends to be reversible. So when you have a patient whose tacrolimus level goes up, if you immediately stop the tacrolimus or reduce the dose, it is reversible. Now, chronic calcineurin toxicity, on the other hand, how does that happen? It happens by inducing endoplasmic reticulum stress. We will look into that. And what happens is when endoplasmic reticulum is stressed, it leads to impaired folding of the proteins, and those proteins then cannot get rid of from the cells, and that they stay in the Golgi apparatus and they make microvacuoles. So it happens because over a period of time, calcineurin toxicity will cause endoplasmic reticulum stress. We'll see how. And when endoplasmic reticulum job is to fold proteins and to get them to the right place, right? Those proteins cannot leave and they become microvacuoles, and those vacuoles ultimately become toxic to the cell. So what happens is, over a period of time, when calcineurins are given, calcineurins directly affect the mitochondria, just like we saw in the previous slide with the other. And it can cause mitochondrial oxidative stress. It increases the mitochondria's energy requirements, or eventually oxidative stress, release of the cytochrome C. Remember, cytochrome C release marks the cell for death, and that's how it causes mitochondrial injury and proximal tubule injury. Same thing happens in the endoplasmic reticulum. It causes endoplasmic reticulum energy demand increase and leads to misfolding of the proteins and proximal tubular damage. And then it also causes expression directly of this gene called P53. You will learn in other branches of medicine, P53 is a gene that inhibits autolysis, which means if the P53 is reduced, those cells are actually marked for damage, for cell autophagy. So it causes P53 expression, and at the end of that, because of the mitochondrial injury and the plasmic reticulum injury and P53 expression, again, caspases are released. And again, whenever caspases are released, that cell is marked for death and it leads to damage. Now, in one previous lecture, I think it was by Dr. Alam, he alluded to the fact that calcineurins over a period of time cause fibroblasts to be excited, and that can cause fibrosis. And that's how you actually get this thing called striped fibrosis. Very much again in the board, they'll show you a picture, they'll show you normal tissue on one side, extreme fibrosis on one side. And that is calcineurin toxicity causing striped fibrosis. So what we're seeing in these pictures over here is proximal tubular cells and distal tubular cells. And you can see these microvacuoles formation. And that is actually happening because of calcineurins. So going back to our question, what is causing this damage? Calcineurin inhibitor toxicity. Now, so phosphate is nephrotoxic, but it causes typical acute tubular necrosis. So you get cell lysis and you get muddy rot cascade, not because of microvacuole formation. Good?
Yeah.
Okay, next question. This is a long question. I'll make it short. 42-year-old man with HIV infection. He's on a tenofovir-based antiretroviral therapy for nearly 3 years. He also has diabetes. I was diagnosed 1 year ago. He's coming to us because of worsening fatigue and muscle cramps. Recently, he had an upper respiratory tract infection 3 weeks ago. He's taking his regular medication and diabetic medication and heart therapy. His examination is not bad, 146/86. Normal sounds, abdomen is perfectly normal. His lab analysis reduced sodium is 136, chloride is 109, potassium is 3, bicarbonate is 20, BUN is 35, creatinine is 1.4. His glucose is 95, and his phosphate is low at 1.1. His CD4 count is well maintained, and his HIV is suppressed. His creatinine used to be 0.7, so over a period of 3 years, it has increased from 0.7 to the 1.4 today. The urinalysis reveals 1 plus protein, negative leukoesterase, negative nitrites, 1 plus glucose, and the sediment reveals 2 WBCs, just some RBCs and no casts. The most likely diagnosis is tenofovir-associated nephrotoxicity, post-infectious GN, he had a sore throat 3 weeks ago, HIV-induced collapsing nephropathy, or diabetic nephropathy. So, which one do you think it is?
What is considered acute because of last year it is one, like previous year it is around 1.4, right?
So it was 0.73 years ago,
Yeah,
and gradually it has increased to 1.4.
and now 1.4, right? It's like this
So it
line
doubled.
doubling, yeah.
Now, what are the important things in the VNX over here? Look here. His potassium is 3. He's hypokalemic. His phosphorus is 1.1. He is hypophosphatemic. What is his glucose? 95. With a glucose of 95, he has 1 plus glucose in the urine. Right?
Yeah,
So hypokalemia, hypophosphatemia, a tiny amount of proteinuria, 1 plus protein in the urine, in a patient who got diagnosed with diabetes just 1 year ago, and is an antiretroviral therapy for 3 years, with gradual increase in creatinine. So, does it fit infectious GM?
No.
No, because the urine is actually bland, right? You don't see any RBC cast. Does it mean HIV-induced collapsing GM? How does collapsing nephropathy present?
That we already collapsing like this, that needs to be more than this one.
Okay, come here.
Collapsing, HIV induced collapsing glomerulopathy.
How does that present? I promise saying something.
Yeah, I'm saying just tenofovir-associated nephrotoxicity could be possible.
Right. So how does HIV-associated collapsing GM present, by the way? It presents with nephrotic syndrome. This patient does not have nephrotic syndrome. He has only 1 plus protein in the urine, right? And which is the last one is diabetic nephropathy. He has diabetes for 1 year, not meeting the timeline. So tenofovir-associated nephrotoxicity is possible. So do the other features, hypokalemia, hypophosphatemia match? Let's see. So proximal tubular nephropathy by tenofovir. So tenofovir is a nucleotide reverse transcriptase inhibitor. While he used to treat HIV and hepatitis B, and is actually very effective, and that's why it is used. The clinical course for tenofovir nephrotoxicity is actually slow. It takes time. And usually, on an average, it takes about 2 years for people to start showing nephrotoxicity. Chronic renal injury and Fanconi syndrome is how it presents. We will see how. So, Fanconi syndrome. What is Fanconi syndrome? It is proximal tubular white nephropathy. Because it's hypokalemia, hypophosphatemia, and a bland urine sediment. And you get low-grade proteinuria, which is tubular proteinuria, and glucosuria. So even patient will have glucose in the urine, even though their serum glucose is normal. Now, tenofovir is an anion molecule. So remember, aminoglycosides were cationic. Tenofovir is an anion. So what happens? Going back to our previous slide, we saw how some of the anions are transported from the blood to the cell, from the cell to the tubular lumen, which means we are dependent on the cellular concentration sometimes. So what happens in tenofovir is, tenofovir molecules are uptaken. So first of all, tenofovir is filtered antiglomerulus, fine. But then tenofovir is actually also dependent somewhat on secretion from the proximal tubule. So tenofovir is uptaken to the proximal to the cell by these transporters called organic anion transporters, OAT1 and OAT3. These transporters bind the tenofovir, basically get the tenofovir from the blood into the cellular tubular lumen. From the tubular lumen, these are excreted out from the cellular cytoplasm. They are excreted into the lumen by these proteins called MRP2 and 4. MRP for multi-drug resistant protein, because these are involved in transport of a lot of other anions, not just tenofovir. Now, what happens is tenofovir itself inhibits these transporters. So MRP2 and MRP4 is actually inhibited by high levels of tenofovir, which means if you have high levels of tenofovir over time, it will be concentrated into the cell fine because of these transporters OAT1 and OAT3, but then tenofovir will inhibit MRP2 and 4, which will lead the tenofovir molecules to stay in the cytoplasm. Now, when the tenofovir molecules stay in the cytoplasm, again, they directly damage the mitochondria. They affect the respiratory transport chain and impair energy production, which causes more mitochondrial damage. And then it affects the replication of the mitochondrial DNA. You might remember we have a DNA in the nucleus, but then mitochondria have their own DNA, right? And it affects the replication of the mitochondrial DNA. It cannot repeat, new mitochondria cannot form. And that's how, over a period of time, the mitochondria lose their function, they become enlarged, and they lose their crisping. And eventually, the cell will be marked for apoptosis. So, one other thing to know, and this again can be tested in the board. Remember how we said tenofovir inhibits MRP2 and 4? There's another antiretroviral medication called ritonavir. And ritonavir very potently inhibits MRP2 and 4. So, it has been shown that if people are given tenofovir along with ritonavir, their chances of tenofovir toxicity is many fold. So these days, we do not use ritonavir and tenofovir combination, but it can very well be tested. If ritonavir is given with tenofovir, chances of tenofovir toxicity bounces very high. Here in this microgram, I'm trying to show tenofovir nephrotoxicity. So this is the proximal tubular cell, this is the basal membrane, this is the apical microvilli, right? You see how these mitochondria look like sausages and they're ballooned, right? And mitochondria, remember they used to have these finger-like structures, like this is a normal mitochondria, right? This mitochondria, they have lost that finger-like structure. If you remember the first picture that I showed, how beautiful mitochondria were there from basal membrane pointing towards the apex, they have lost their their alienation as well. So mitochondria are swollen, they have lost their alienation, they have lost their finger, that's tenofovir toxicity. Now, this can also be tested on the board. Tenofovir comes in two forms. TDF, which is tenofovir disopropyl fumarate, disoproxyl fumarate, and the newer product called TAF, tenofovir alafamide. What we use these days is TAF, tenofovir alafamide. And why that is because although both formulations are tenofovir formulations, and both of them are renally excreted, alafamide, after introducing to the patient, is immediately taken up by mononuclear cells. And that very small concentration of TAF is available to be secreted by the proximal tubular cell. And that's why the damage, the nephrotoxicity of TAF is much lower than TDF. So whenever you see tenofovir these days, it actually should be a TAF formulation because of that function. So tenofovir should be TAF, not TDF. So if there's a question that tells you which one of the two to choose, TAF is what you will choose. So going back to our patient, this patient is showing signs of Fanconi syndrome. He has glycosuria with a normal glucose level, hypokalemia, he is hypophosphatemia likely because of phosphaturia, with a glandular sediment and just 1+ protein. This is more than likely tenofovir associated nephrotoxicity. Good?
Yeah.
Okay, now we will go to some spot diagnosis so we can make it fast. Nephrology has been caused by infectious disease for acute kidney injury on an inpatient being treated inpatient for encephalopathy. The medical student who saw the nephrology consult reports patient is on some intravenous medication but cannot remember the name. However, urine has been collected. So before you go see the patient, you actually look at the urine sample under the microscope. And this is what you see. So on the left side is high-power microscopy, and on the right side is contrast phase microscopy.
This is crystal, right?
These are crystals. What medication can do that?
Cyclopyr.
So patient is getting treated for encephalopathy, right? These are acyclovir crystals. The needle-shaped crystals that are birefringent, acyclovir crystals.
So my question is always completely, okay, I know cyclopyr, but if the patient, digestion, methyl alcohol or whatever the glycol, antifreeze. Antifreeze. And they give it the ER for encephalopathy. This is the same picture I saw in your analysis, crystal also, or no?
No.
No?
No. Okay, we'll see. All right, another spot diagnosis. 44-year-old woman with fibromyalgia, hypertension, and bipolar disorder was found confused in a garage. In the emergency department, she's intubated and ventilated, so you don't have much of a history. Patient was taking naproxen, losartan, acetaminophen, and lithium. Blood pressure is 90/60. Everything else on examination is pretty good. Of course, she's altered and she's intubated. Natriuretic release sodium is 143, chloride is 104. I marked some of this for help, bicarbonate is down to 8. Renin gap is 31. B1 is 25, she's in kidney. A serum osmolarity is 395. Our arterial blood gas shows a pH of 7.04, extremely acidemic, and partial pressure of carbon dioxide is 30. The analysis reveals trace protein and 1 best test trace. Okay? The urine sediment reveals this.
Oh, yeah.
What are these?
This is my question. This also but it's also considered crystal, right?
Well, everything is crystal. What kind of what crystal is that?
This is for the antifreeze. What is the name of the crystal?
Yeah, these are calcium oxalate crystals. Envelope shaped calcium oxalate crystals. So you have a patient who's encephalopathic, extremely metabolic acidosis, very high serum osmolarity, and you got calcium oxalate crystals in the urine. What's the diagnosis? Antifreeze toxicity, right? Okay. 59-year-old man with hypertension and osteoarthritis was evaluated for excruciating back pain, AKI, anemia, and hypercalcemia. Patient has been taking ibuprofen 3 to 4 times per day, along with losartan, hydrochlorothiazide, and aspirin. Examination released normal white sign. Of course, he has spine tenderness. Sodium 134, potassium 5.5, bicarbonate is 18, BUN is 65, creatinine is 6.1, his calcium is 14.6. And his phosphorus is extremely elevated at 9.7. So high calcium, high phosphorus, acute kidney injury. Thoracic spine lytic lesions were demonstrated on the X-ray. Urinalysis shows trace protein, but is otherwise negative. His urine sediment shows tubular epithelial cells and vaccine cancer. The spot protein to creatinine ratio was 4.8 milligram per gram, so that is nephrotic range proteinuria. A kidney biopsy is done for this patient with hypercalcemia. And you see this. What do you see?
Amyloid.
Okay, I have a taker for amyloid. Another taker?
And we just put back to the question.
So let's talk about the structure. What are these? So not the red thing. What are these? What kidney structure is this?
This considered also the view, right?
Huh?
This is the left side. This one glomeruli, right?
Does this look like the glomerulus? So glomerulus has a lot of capillaries, right?
Yeah.
There are no capillaries.
Yeah.
Look at the cells.
You.
Tubular epithelial cell. This is tubule.
Yeah.
So these are tubular cells, and you see something red in the tubular cells that is blocking the tubules. That's a cast, right? This is not glomerulus. Amyloid affects the glomerulus, and yes, you can see free amyloid in the interstitium. But in the right scenario, this patient is coming in with lytic lesions, severe hypercalcemia, acute kidney failure. He has chronic low back pain, and he's also anemic. And he has nephrotic range proteinuria. What is this?
Multiple myeloma.
That's right. So this is cast nephropathy. Right? Light chain cast nephropathy. Now, what light chains cause cast nephropathy?
Like chains.
Kappa, lambda?
Oh, kappa.
Right. So actually, any of them can cause. It's just that statistically, kappa causes more cast nephropathy. I remember it with K and C, right? Kappa causes cast nephropathy. So kappa is more likely, but you can see cast nephropathy with lambda as well. So that's cast nephropathy. Okay. So spot diagnosis again. 65-year-old man presents for evaluation of rising serum creatinine. His node positive myeloma was diagnosed 2 months ago, and he has been treated with adjuvant pembrolizumab every 3 weeks. Pembrolizumab is newer medication, and it is a monoclonal protein, and I'm missing the mark. Oh my gosh, Dr. Vyasa, what class of medication is this? These are immunotherapy. Yeah, this is an immunotherapy medication. Pembrolizumab is an immunotherapy medication. Every 3 weeks after surgical resection. His other medication include pantoprazole and amlodipine. He has been receiving a total of 3 cycles until now. Niacin, nausea, vomiting, diarrhea, skin rash. His blood tests show a rise in serum creatinine from baseline of 1 to 1.6 now. The analysis shows 1 plus protein, 1 plus leukocytes, 1 to 5 WBC cells per hyper. There are no casts. The saving culture is no growth. Urine protein creatinine ratio is 0.4.
What was the question? Sorry, Dr. Rathi. Rathi,
no, you're good. Pembrolizumab is an immunotherapy. I was missing that word. So pembrolizumab is held and is given during a lactate. The ultrasound examination shows that patient kidneys but the patient's repeat serum creatinine 3 days later is even higher at 1.8. So it was 1.4, he received 3 cycles, 1.6, stopped the medication, and still 1.8. Okay? The kidney biopsy shows this. What do you see?
Also, the deposit is it cells like.
So again, let's see what structure we're talking about. What are these? Tubules. Tubules. Tubules, right?
Interstitium.
This is a testicium. And in the testicium, what do you see? Is it looking like a normal testicium? Hypercellular, lots of cells. Right? Now, if you look at these cells, some of these are mononuclear cells. Right? Right? So, a lot of inflammation, mononuclear cell inflammation in a patient who's coming with acute kidney injury and is on an immune-mediated medication. What's the diagnosis?
Interstitial nephritis.
That's right. It's acute interstitial nephritis, and immunotherapy medications are actually a known cause of acute interstitial nephritis. So much so that sometimes you have to stop the medication. Now, a lot of the time, depending on how severe the interstitial nephritis is, the disease may progress because remember, interstitial nephritis is not a dose-dependent condition, right? It is an idiosyncratic, which means once the T cells are activated and they start going into the CD4 hypersensitivity cycle, the disease can progress. Now, a lot of the time, these patients will be treated with infliximab. So, your chemo medications, because you can't just stop, there are newer protocols where they will be given steroids and infliximab, like interleukin inhibitors, and still continue the medications if this is their last resort. That's all I have for today.
Thank you.
Oh, thank you so much. Thank you.
Any questions?
gonna get-
Dr. Reza?
Thank you, Dr. Rathi.
Thank you. Yeah, no question. We're gonna get the
No,
lecture,
one
right?
thing I missed is actually the diagnosis on the.
Oh, did you lose it?
No,
Dr.
the
Reza, can you hear us?
marathon runner,
Yes.
I missed the answer.
Right, so we were saying that a lot of those options could
Yeah,
be possible.
there is a delay, when I talk for some reason.
Right, so what we said is a lot, out of those 4, 3 of them seem
Yeah,
to be
18 is
possible.
possible. What was the answer for that question?
It was the bland urinalysis because this person is
Yeah, which was the
otherwise
actual answer?
That is the actual answer, bland urinalysis. Because it appeared to be hemodynamic. He was actually
Yeah,
had a
but
strenuous
saying that
training cycle.
when he's
What? Sorry, Dr. Answer?
yeah, but saying that he could have ATN even with 1 or 2 doses if he's dehydrated.
Right, but so ATN in patients with nephrotoxic exposure usually takes few doses, like more than just a handful of doses, because it needs to be long enough that the COX-1 and COX-2 impairment in the loop of NLA is affected, which in a very maintained hydrated patient otherwise would be less likely. So if you are taking it for a prolonged period, that's when you start getting into the cycle of ATN.
Yeah, okay.
Thank you.